You went through the consultation, the imaging, the surgery, the healing, months of your life and a real financial investment, all to get a result that looks and feels remarkably close to the natural tooth. And now someone's telling you that you still have to take care and maintain it. Yes, you do. And this video is going to tell you exactly what that looks like. Because what nobody explains clearly enough at crown delivery is that an implant is not a set it and forget it solution. The titanium post doesn't decay, but the biology surrounding it absolutely can fail. And when it does, it's usually silent, until it isn't. Let's get into it. What's up everyone, Dr. Eric Jackson here, hope you're doing well. I've been practicing dentistry here in Downers Grove for almost 20 years, and today we're talking about something that doesn't nearly get enough airtime after implant delivery. How to protect your implant for the long term, what maintenance actually looks like, and how the things that most patients don't know can quietly destroy an implant that was placed perfectly. If you didn't catch our recent implants video or bone graft video, I'll link both below. That way you can get caught up. But the short summary is that an implant is a titanium root replacement that fuses directly to your jawbone. It's extraordinarily stable. It stimulates the bone the way a natural tooth does. And when it's placed on a well-preserved foundation and restored correctly, it can last decades. But here's what the implants video touched on briefly and what we're going to go deep on today. The surgery being complete does not mean the work is done. Protecting the result is lifelong. I want to start here because it frames everything that follows. And I want to say this about dentistry in general, not just about implants. Patients sometimes think of dental work the way they think of replacing a part in a car. A filling goes in, a crown goes on, an implant gets placed, and it just works. Done. That mental model applies pretty well to a lot of things in life. Engines, appliances, plumbing, but it does not apply to dentistry. Because nothing we place in your mouth lives in a mechanical environment. It lives in a biological one. The bone is alive. The gum tissue is alive, and living tissue responds to how you take care of it and how you don't. That's true of a single crown, that's true of a full set of implants, and it's true of everything in between. This concept includes patients with implant-supported dentures or implant-supported bridges as well. I hear this one regularly: I don't have teeth to clean, so maintenance doesn't apply to me anymore. It absolutely does. The implants still go into bone. That bone is still organic tissue. The gum tissue around those implants is still alive. Neglect finds it just as reliably as it finds any natural tooth. You may not have individual crowns to brush, but you still have a biological environment that requires maintenance. Here's the most important thing I can tell you about implant longevity, and it's something most patients genuinely don't understand. An implant cannot get a cavity. There's no enamel, there's no dentin. Decay is not the threat, but bone loss absolutely is, and it happens through a completely different mechanism than what destroys natural teeth. The condition is called Peri-implantitis. Think of it as gum disease specifically around an implant. Bacteria colonize the implant surface, the surrounding tissue becomes inflamed, and over time that inflammation silently erodes the bone that's holding everything in place. By the time it's painful, you're already dealing with a serious problem. An implant is not immune to neglect, it just fails differently. Here's a simple rule that applies to every tooth and every implant in your mouth. Healthy gum tissue should not bleed routinely when you brush, floss, or use your Waterpik. That's true around natural teeth, it's true around implants. If you're seeing persistent bleeding anywhere in your mouth, that's inflammation telling you something. Don't ignore it. The earlier we catch it, the easier it is to manage. It's not something to wait out. Another thing patients often notice before we see radiographic changes is food trapping. If food suddenly starts packing around an implant that never used to trap food, that's worth mentioning at your next visit. It may be nothing, but it also may be an early sign that the tissue architecture around the implant is changing. Early conversations are always better than late ones. Before I get into the tools, I want to say something that I think is worth acknowledging. The overwhelming majority of dental implants are placed for one of three reasons: periodontal disease, a fractured tooth, or decay that progressed beyond what could be saved. And all three of these, more often than not, have a behavioral and habit component. Years of less than perfect home care. Periods of life that got in the way of things that we know we should be doing. This is not a judgment. I've been a dentist for almost 20 years, and I've never once met a patient who sets out to lose a tooth. But I think it's a fair and honest thing to say. And here's why I think it matters. The implant represents a fresh start, not just mechanically, biologically. You have a clean foundation, and what you do with it from here is entirely in your hands. The patients I see do best with implants long term are the ones who treat crown delivery not as the end of the story, but as the beginning of the different one. That's what this section is about. Let me give you a benchmark. What should a healthy implant feel like? No mobility, no pain on biting or chewing, no swelling of the surrounding tissue, no persistent bleeding when you clean it, no new food trapping, No bad taste that wasn't there before. No visible pus. If any of those change, call us. That's what the list is for. Plaque still matters. That's the part patients most often miss. That's because there's no cavity risk. They assume cleaning around the implant is optional. It's not. The difference is technique and tools. Around an implant, the right tools can matter even more than they do around natural teeth, because the anatomy is different, and the space that needs to be cleaned is different. Let me explain what I mean. Standard string floss is designed to clean the contact point between two teeth and just slightly below the gum line. That's what it does, and it does it reasonably well in the right context. But here's their limitation. The gum tissue itself physically stops the floss from getting very far below the surface. That's fine around natural teeth because the root narrows and the architecture is forgiving. But around an implant, that's a problem. Implants are often placed quite far below the gum line, and the proximal space, the space between the implant and the adjacent tooth, is considerably larger than what you'd see between two natural teeth. That's especially true in the molar region, where the implant post is far narrower than the natural molar it replaced. At crown delivery, I'll often pull up an x-ray and show patients this directly. A natural contact on one side, an implant contact on the other. The difference in space is immediately obvious. String floss by its nature can really only clean what it can reach at the gum line. A significant amount of what needs to be cleaned around an implant is below that line, in a wider space where floss struggles, or simply can't get to. The Waterpik changes that equation. A water flosser drives a pressurized stream of water below the gum line, around the abutment, into that proximal space, and under the crown. Areas that floss cannot access effectively. This is the tool that actually cleans where an implant needs to be cleaned. It's not an upgrade. It's not optional. It's baseline. Let's talk interproximal brushes. Small tapered brushes that fit between the teeth and around the implant margin. They're a useful supplement. Your hygienist will fit you to the correct size at your visit. One important note though, never force one where it doesn't fit. If it doesn't slide in comfortably, that's not the right size for that space. Forcing it can damage the tissue. Don't shove. And when in doubt, stick with the Waterpik. And your toothbrush matters more than most patients assume. A manual soft bristle brush is the absolute bare minimum, the bargain basement option. But what I'd rather see you use is a rechargeable electric toothbrush, like a Sonicare. The sonic action drives the bristles down into the sulcus and around the implant margin in a way that manual brush simply cannot replicate. And that matters here, because the surface area that needs to be cleaned around an implant is much larger and harder to reach than what you'd have around a natural tooth. The same logic that takes you from string floss to Waterpik applies to your toothbrush. Better tools makes a real difference when the space demands it. These are not suggestions, they are the maintenance program. Now I want to talk to you about something mechanical, because this is where the car analogy actually does apply. When you hit a pothole in a car, the wheel takes the impact, the shock absorber compresses, and the chassis is protected from the full force. Your natural teeth work the same way. There's a ligament, the periodontal ligament, that sits between the tooth root and the bone. It has microscopic give. It absorbs force before it transfers to the bone. It's the shock absorber. An implant has no periodontal ligament. The titanium post goes directly into the bone. There is no give, no cushion, no shock absorber. When the force hits an implant, it goes straight to the bone. For most patients under normal biting conditions, that's not a problem. The implant is designed for it. But if you grind or clench, even mildly, even without knowing it, even only at night, you're putting a cyclic asymmetrical force on a titanium post anchored directly in the bone, with no cushion between them. Over time, excessive bite forces can contribute to bone loss around the implant, mechanical complications like screw loosening or component fracture, and can make peri-implant disease considerably more difficult to control. Whether the problem starts biologically or mechanically, the end result can be the same: loss of supporting bone and ultimately loss of the implant. Night grinding is one of the quietest threats to an implant that exists. This is where I tell every patient the same thing at crown delivery. If there's any indication you clench or grind, even mild, even asymptomatic, a night guard is not optional. It's a protection for your investment. I first came up with the concept of triple play dentistry back when I was a team dentist for Chicago Bandits professional softball team. The idea is low cost, low invasiveness, high return on investment. A custom night guard fits all three of these criteria perfectly. It provides padding and separation of the bite surface. Think of it as a bicycle helmet for your implant. The forces are distributed, the bone is protected, and the implant has a much better chance of lasting the rest of your life. Now, over-the-counter guards do exist, and I want to be clear about exactly where they fit in this conversation because it's more specific than it sounds. In my practice, I use over-the-counter in two situations. The first as a bridge. When a patient decides they want a custom guard, there's a fabrication window. A digital scan, lab, delivery, that's a few weeks. Sitting completely unprotected during that window is worse than having something in place that's temporary. So I'll often recommend an over-the-counter guard to wear while the custom one's being made. 2 to 3 weeks, that's the total job for the over-the-counter guard. The second is as a diagnostic. I hear it often at recall exams. I don't grind, I don't have any pain, my spouse never heard a thing at night. And sometimes that's true, and sometimes it's not. And the evidence is quietly showing up in the wear patterns in the bone. So I'll suggest that the patient tries an over-the-counter guard for a few weeks. If symptoms improve, better sleep, less jaw soreness in the morning, even subtle things, that tells us a lot. It moves the conversation forward when a patient wasn't sure there was a conversation even to be had. But here's what I want to be completely transparent about, especially for anyone watching this who has a dental implant. The manufacturer instructions for these products, and I'll use the DenTek Ultimate Over-the-Counter Night Guard as an example because it's one of my favorites of the group, explicitly states do not use this if you have dental implants. They also say not to use for more than 3 months without consulting a dentist. The device is not designed or tested for long-term use with implants, or for that matter, without implants. So in the context of this video, if you have an implant, an over-the-counter night guard has a very specific and very time-limited role. 2 to 3 week bridge while your custom guard's being made. It's not the destination. It's not the long-term answer. The custom guard is. If cost of the guard is a concern, that's a conversation I want to have with you in my office, because the alternative, grinding unprotected on a titanium post anchored directly to your jawbone, is an expensive conversation too, just of a different kind. One more thing patients assume they're past once the crown is delivered, the risk from smoking. The implant is integrated, the surgery is complete, but the biology around it is still living tissue, and smoking continues to impair that tissue. Constricted blood vessels, reduced oxygen at delivery, chronic inflammation, all of it continues to affect the gum and the bone around your implant. Smokers have a significantly higher rate of peri-implantitis. That risk doesn't disappear after osseointegration. And I'll say this, if you've been thinking about quitting, this is a genuinely good moment to have that conversation. There are more effective options available today than there ever have been before, both over the counter and prescription. And the evidence behind some of the newer approaches is very strong. It's worth a conversation with your medical doctor or with me. As your dentist, I'm probably not the right person to manage your smoking cessation program directly, but I am very happy to talk you through with what's available and point you in the right direction. You've already made a significant investment in your oral health. Protecting it is a reasonable next step. Diabetes deserves a mention here as well. Poorly controlled blood sugar increases inflammation throughout the body and can make it considerably harder for the tissue around an implant to remain healthy long term. If you're a diabetic, keeping your A1C under control is not just good for your cardiovascular health, your vision, and your kidneys. It's good for your implant too. Most patients have never connected these dots. Now you have. Here's something that's becoming increasingly important, and I want to be straightforward that this is an emerging area of research. We're seeing growing evidence that certain prescription medications that are extremely common and that patients may have started well after their implant was already placed and functioning perfectly, are associated with implant failure in patients who were otherwise doing just fine. Not because of infection, not because of grinding, not because of neglect. Implants that had been successful for years suddenly failing after a prescription change. The two most studied right now are SSRIs, that's antidepressants like Prozac, Zoloft, and Lexapro, and proton pump inhibitors, which are acid reflux medications, things like omeprazole, Prilosec, Nexium. Research has shown an association between both of these medication classes and increased implant failure rates. And when unexplained bone loss shows up around an implant in a patient who's been on one of these medications long term, that medication now has to be considered as a possible cause. I want to be clear about something important though. Association does not prove causation. Many patients take SSRIs or proton pump inhibitors for years and their implants are perfectly fine. These are among some of the most commonly prescribed medications in the country. A lot of patients are on one or both of them, and most of them have no idea there's any connection to their implant. This is not a reason to stop your medication or adjust your dose though. That's a conversation between you and your physician, not me. But it is a reason to keep the lines of communication open between your medical team and our office. If your prescription changes, tell us. If you start something new, mention it at your next visit. We're not going to catch medication changes we don't know about, and the research on this is only going to grow. I want to say something directly here because I see it pretty often, and it needs to be said. Patients come in, and when we ask about medications, medical history, recent changes to their health, they leave things out. Not because they're being dishonest, because they've decided on their own that it's just not relevant to the conversation, that we're just dentists. That what's happening with their cardiologist or with their psychiatrist or with their internist has nothing to do with what's happening in their mouth. That's absolutely wrong. It has everything to do with what's happening in their mouth. Your mouth is not a separate system. It's part of you. The medications you take, the conditions you manage, the changes in your health, all of it lands here too. We cannot give you the best possible care if we're working with an incomplete picture. And we're not going to know the picture is incomplete unless you tell us. This is the same in all of medicine. Your cardiologist wants to know what your orthopedist prescribed. Your anesthesiologist wants to know a full list of medications before you go under. We are no different. The only difference is that patients have historically not thought of us in that way. We're not just dentists. We're part of your medical team. Treat us like it and let us do the same for you. Think about the car analogy again. A high-performance vehicle needs regular service, not because something's wrong, because you want to catch what's developing before it becomes a problem. Your implant recall visits are the same. We take periodic radiographs to check bone levels, we probe around the implant, we check for mobility, we evaluate the bite. We look for early signs of peri-implant inflammation, bleeding that's not normal, food packing, tissue changes. Caught early, most of these are manageable. Caught late, most of them aren't. One of the most frustrating realities of implant disease is that patients often feel perfectly fine while the bone loss is occurring. An implant can lose a meaningful amount of bone support before it ever becomes loose, painful, or obviously problematic. By the time it's symptomatic, the conversation has gotten much harder. That's why periodic radiographs matter. We can see things long before you can feel them. Small problems become big problems quietly. That's the nature of implant failure. It doesn't announce itself with pain until it's serious. Your recall schedule is your early warning system. Patients always ask me, how long is this going to last, do you think? And my honest answer is, I don't really know. If I knew the future, I'd be a stockbroker and not a dentist. What I can tell you is this: you can buy one of the most reliable cars on the road, a Honda Civic, maybe a Toyota Corolla, and not every one of them makes it up to 200,000 miles. Some fall short, some go even further. And a lot depends on how you drive it and how well you maintain it. Hard drivers get worse outcomes. That's true for cars and for teeth and for dental implants. An implant placed on a solid foundation, cleaned properly, protected from excessive bite forces, with medication changes communicated to our office, and monitored at regular recall visits, has an excellent long-term track record. The research supports it. What undermines it is almost always biology and behavior, not the actual implant itself. Advice is given. It's either heeded or not, and outcomes result. One final misconception I want to address, because I see it cost patients money regularly. The implant may not decay, but the teeth around it absolutely can. And the gum tissue and bone around the adjacent teeth is just as vulnerable as it ever was. Some of the most expensive treatment plans I see are not failed implants. They're perfectly healthy implants sitting next to teeth that were just never maintained. The goal isn't protecting the implant, it's protecting the entire mouth. The implant doesn't exist in isolation. It exists in a biological environment, which is exactly where we started this conversation. You made the investment, you did the healing, you have a restoration that, when maintained properly, can serve you for decades. That's not an exaggeration. That's what the data shows when patients do their part. The maintenance program is straightforward. Waterpik, proper technique around the implant, a night guard. Keep your medical team and your dental team in the same conversation about your medications and your health. And, of course, regular recall visits so we can catch anything early. If you have a dental implant and haven't been back for a while, come on in. Let's take a look, check the bone levels, make sure everything is where it needs to be. It's a much easier conversation than the alternative. If you did not catch any of the prior videos of this series, I'll link them all below for you. In our next video, we're going to do a deep dive into how to heal and maintain your recent socket grafting or bone grafting procedure. So if you're interested in that, you're going to want to check that one out. Stay tuned. You'll find us at Jackson Family Dentistry, 2033 Ogden Avenue in Downers Grove, Illinois. Give us a call at 630-963-6750 or find us at jacksonfamilydentistry.us. New patients are always welcome, and we'd love to take care of you. You already did the hard part. The consultation, the imaging, the surgery, the healing. The maintenance is the easy part by comparison. A few minutes a day with the right tools and showing up for your recall visits, that's pretty much it. The investment is already in. Now you've got to protect it. If you thought this video was helpful, give it a thumbs up and hit subscribe. I put out content like this regularly. I'm extremely passionate about modern dentistry and love talking about it. So if you have any questions, put them in the comments below. I actually read them. I'll get back to you as soon as I can. Till then, I'll see you in the next video. Bye now.